So the current guidelines in CLL look at a number of factors in terms of what we think is the prognostic implications and also what we call the predictive. So prognostic is how long it takes someone from diagnosis to requiring treatment. Predictive is how do they respond to a particular treatment. The most important of those features are the presence of a p53 abnormality, either a mutation in TP53 or a deletion in 17p. The other important factor is the immunoglobulin mutational status, those patients with unmutated immunoglobulin genes having a shorter time to need of treatment, that is a poor prognostic feature, and certainly for chemoimmunotherapy, also a poor predictive indicator, that is those unmutated patients having less durable responses. Now, what we've seen is that predictive factors matter depending on which therapy you're offering. For instance, for BTK inhibitors, we're largely seeing the outcome of mutated and unmutated patients being quite similar, so that that agent is able to overcome that poor predictive marker. So you have to think about which are the factors you want to look for and how they respond to particular therapy. Now, this moves us towards a targeted treatment approach whereby you select the right therapy based upon what's the best outcome I can have for a patient based upon largely those two markers. Now, there's a lot of science going on behind the scenes, and we're seeing a lot of that presented at the meetings here about other markers, other mutations that occur but with much lower frequency. But right now, in everyday clinical practice, those are the two markers that we're using to select our therapy in CLL.